It's the weekend. Be good to yourself. It's Katz's Corner with Dr. Aaron Katz and Dr. Philippa Cheetham, where you can get simple, straightforward answers to your questions about health, from diet and supplements to lifestyle changes. To reach Dr. Katz and Dr. Cheetham, call 800-848-WABC. Now, live on 77 WABC, the chairman of urology at Winthrop University Hospital in New York, with co-host Philippa Cheetham, attending in urology at Winthrop University Hospital. Here is Dr. Aaron Katz.
Good morning, everyone. Welcome again to another live round of Katz's Corner here on WABC Radio in New York. I'm your host, Dr. Aaron Katz, and we're live. Welcome, everyone. So glad you could join us and be with us here on WABC Radio. My wonderful co-host, Dr. Cheetz, is away for the weekend, enjoying some spa time alone. But we have with us a wonderful guest in the studio. We're going to get to him right now. But before we do, I just want to again remind everyone that we are having our Men's Health Seminar this June. That's June 15th at the Garden City Hotel. It will be a wonderful event. We expect probably over 300 people. People are already signing up onto the website, which is menshealthseminar.com. Menshealthseminar.com. You need to sign up and register. Bring your friends, your spouses, your loved ones. Let them all know. We're going to have a full day of wonderful lectures. We'll be discussing a lot of information about your prostate, but also cardiac health, bone health. So we'll have some lectures about how to monitor your weight and how to improve your sleep. All wonderful things for your health. Please register now at menshealthseminar.com. This morning, we have a wonderful guest in the studio with me, a colleague at Winthrop University Hospital out in Mineola, Dr. Scott Schubach. Scott is the chairman of thoracic and cardiovascular surgery at Winthrop. He is an outstanding physician and has done some very innovative work in the area of cardiovascular research and in innovating new techniques that we will discuss this morning. He trained at the University of Pittsburgh. He has a wonderful resume, which would take us all morning probably to go through. Well, good morning, Scott. How are you?
Good morning. Happy to be here.
Great. Thanks so much for joining us. And if you have a question about your heart health this morning and you'd like to speak to Dr. Schubach, who is an expert in the area, give us a call at 1-800-848-9222. So, Scott, at Winthrop, I know that you run a very active program there. Tell us what's new. I know that you have this exciting program called the TAVR, the transcatheter aortic valve replacement. What is that all about?
Well, it's a very exciting program. This is a new technology that's been studied internationally, Europe, many academic centers throughout the nation for over 10 years. And what was trying to be developed was a less invasive way to treat a disease known as aortic stenosis. Aortic stenosis is an abnormality of one of the heart valves called the aortic valve, which is essentially the last valve as the heart squeezes blood out to the body. That valve, over time in some people, becomes narrow. We don't know why some people get it and some people don't, but as it becomes narrow, the workload on the heart becomes quite extreme. And people present with the main symptom is shortness of breath. And we've been treating it for years with open surgery. Similar, I'm sure the listeners have friends or relatives that have had bypass surgery or valve surgery, and it does require a major incision in the chest. And still, that's the standard of care. But if as you get older or more debilitated, that becomes a hard surgery to get through. So this technology called transcatheter aortic valve replacement, or TAVR is the acronym that we used, has been developed. And it was FDA approved approximately 1 year ago. And Winthrop was actually one of the first institutions privileged or allowed to do this new procedure. We have a very coordinated, integrated team. We've provided high-quality cardiac surgery at Winthrop for over 30 years. I've been there for 20 years. And we've now been doing the procedure. And when we first were allowed to do this, we anticipated doing 10 to 15 of these procedures the first year, and we're already up to over 70 procedures.
Wow.
And with an excellent result. And the key is yes, it's less invasive. It does not replace our standard techniques, which still has excellent results. But it really has allowed Winthrop to provide care to those patients that had no options going back a few years ago. And that's what's really exciting about this.
Well, let's take it back one step further, and this is very exciting news. I assume that this is still heart surgery, though. Considered heart surgery. I mean, you need a valve replacement, so do you have to stop the heart when you're doing this?
Interestingly, no. With the old way or the present way, yes, we do stop the heart. With the old way, we actually take the old heart valve out and put in a new valve. With this new transcatheter technique, we don't stop the heart. We use catheters that go either through the blood vessels in the groin or directly through the heart in a very controlled. There's still full anesthesia. There's no discomfort whatsoever. But the heart does not have to be stopped. And while the heart is actually functioning, we were able to inflate a balloon that inserts a new valve while the heart's beating, and instead of removing the old diseased valve, pushes that old diseased valve out of the way. And now you have a new functioning valve in place.
That's phenomenal. That is phenomenal. Now, let me ask you, you mentioned that the patient would know he has this because of shortness of breath. Now, a lot of people have shortness of breath, and they don't have this condition, right, this aortic stenosis. So is this shortness of breath something that you just, is it when you're running and you're short of breath, or you're walking up a flight of stairs and short of breath, or you just wake up from your sleep and you're short of breath?
Well, it really runs the spectrum. There are a lot of people around who have aortic stenosis who don't know it yet. But if you're short of breath, it can be debilitating, where you can barely do your activities of daily life, to someone who says, listen, I could do the marathon last year, and now I can only do the half marathon. Now, those are really two big extremes. And you're right. A lot of people have shortness of breath for other reasons. But if your symptoms have changed to something new, of course you're going to go to your medical physician.
And how would you make that diagnosis? You'd have to have some type of would it show up on an EKG?
It's actually a physical finding. You go to your medical physician. I'm not feeling well. The physician says, well, what's wrong? He says, well, I'm having trouble breathing. And then the internal medicine doctor or family practitioner has a list of things it could be. And one of the first things that a physician will do is listen to your heart. And it's usually the physician will hear a murmur, a heart murmur. Now, a heart murmur can mean many things, most of which are very benign, and no one should worry. So I don't want people listening to go to their doctor. They say you have a murmur, and oh my God, I have aortic stenosis. However, if you have shortness of breath and your physician hears a murmur, then the next step is a very non-invasive step. You mentioned EKG, which shows you heart rhythm, but there's a test we've been doing years called an echocardiogram, which is an ultrasound test. And there's a probe that goes on the surface of your chest, non-invasive, with a little jelly. It can be done awake. It takes approximately 15 minutes. And that will be the test that says yes or no, you have it, and then also the degree. The interesting point is, if you have aortic stenosis, again, to the listeners, it doesn't mean that you have to run and have heart surgery, whether the less invasive or the standard way. There's a whole gamut of aortic stenosis and the degree of severity.
Is there medical treatment for this? And when you say stenosis, so that's, I guess, a narrowing.
Narrowing.
Is it? We talk a lot on Katz's Corner about inflammation, especially in the prostate and the body. Is it due to inflammation or diet in any way that particularly affects this valve? I mean, why would this one valve? Because we have how many valves in the heart now? We have
4 valves.
We have 4 valves. We have 4 chambers, right?
That's correct.
Right. Okay. I see. I went to medical school. We have 4 valves, but yet this one valve is the one that could really have a major impact on our life. What is it about that valve? Is it inflammation? Is it diet related in any way or not?
Well, that's a good question. The first point is you're right. There are 4 valves.
Right.
And actually, all 4 valves can be diseased. We tend to focus on 2 valves in the adult population called the mitral valve and the aortic. The reason we're discussing the aortic valve today is because of this new technology that is specific for that valve problem. The other interesting point is you said stenosis is narrowing, and that's in fact true. And a valve, just like in any piece of machinery, your car, a valve opens and closes, which means it can do one of 2 things wrong. Not open right, which we talked about as stenosis, or not close right, and that's called an insufficient or regurgitant valve. Now, to answer your question, what causes that? There has been years and years of research, and no one really has pinpointed. We think that inflammation plays a role in a lot of abnormalities, like you said, with the prostate and any of the systems, whether it's the GI system, the cardiac system. People often wonder, well, is it related to what we call coronary artery disease, atherosclerosis, or blocked arteries? And that's the most common cardiac abnormality that the public is aware of. And we know that smoking, poor diet, obesity, high blood pressure, genetics all play a role with coronary artery disease, and it has been presumed that there may be some relationship, but that has yet to be proven. So in answer to your question, we know a lot of what causes these things. We think inflammation plays a role, but why one person gets it and one person doesn't has really not been specifically answered. Regarding medical management, in the early stages of aortic stenosis, people can do very well for quite a long time. The heart is quite resilient. We treat the associated problems, whether it be high blood pressure, if people have what's called congestive heart failure, a fluid pill, it's called a diuretic, and that helps people remain stable until we determine it's time for surgery. But really, other than surgery or this new procedure, that's the only way to alleviate the problem.
We're talking with Scott Schuback this morning. He's the chairman of thoracic and cardiovascular surgery at Winthrop University Hospital. If you want more information about this new procedure called TAVR, which is the transcatheter aortic valve replacement, which sounds like we're doing, probably one of the most in at least in the region here on these new procedures. There is a complete multidisciplinary team, a coordinated care team approach at Winthrop with cardiothoracic surgeons and cardiologists. You can always go and reach and hear more information and get more information at winthrop.org. That's winthrop.org. And Scott Schuback is our guest and talking about this new procedure. We're just going to take we have a lot of phone calls, Scott, so let's just take one. Here's a gentleman on the phone who has prostate issues and a heart problem. That's Paul in Paramus. Good morning, Paul.
Yes, good morning, doctors. I'm so pleased to be able to speak with both of you about my situation because I was just diagnosed with prostate cancer, and 7 months ago they found I had atrial fibrillation and a regurgitative mitral valve, and I was looking into robotic prostatectomy. One urologist states that I could get through the surgery within the next 4 or 5 weeks, and another says the condition of your heart, my ejection factor is 40. Wearing a Holter monitor, I had a pulse rate of 46 at 7 a.m. and 150 at 9:30 p.m. The second surgeon suggests that I should consider getting AFib taken care of.
All right, and Paul, how old are you, Paul?
67.
All right, so 67, and how bad is the prostate cancer? Is it what's the Gleason on that?
The prostate cancer is a Gleason 7.
Okay, so and what's the PSA that value?
The PSA in October was 10.2 and 12.6 in December.
Okay, so it sounds like you have some intermediate risk features there, and you may benefit from robotic surgery, which is going to be a 3 to 4 hour procedure with general anesthesia. Scott, Dr. Schuback's our expert in the studio this morning. How would you advise this gentleman if he came to see you, Scott? He's being prepared, I guess, getting ready for general anesthesia. What do you think about his heart condition?
Well, like we were talking about just recently, the range of symptoms, I think what's interesting when evaluating somebody, you gave us a very good report about your heart. My question to you is, how active are you? How do you feel? And how have things changed recently? Not so much regard to your prostate, but just your activity level, which gives us a better sign of how much reserve you have. Regarding your fibrillation in the mitral valve, yes, eventually I think it'd be something that needs to be addressed, and whether it's before or after, I think how acute is the word I would say. How active are you? Have you noticed any changes?
I'm 100% active. I walk an hour a day, and I get a slight out of breath if I ascend a set of stairs, but I recover quickly, and they did a stress echo, and after 18 minutes, they told me it's time to stop, and I could have continued to go, and they made that remark, but nonetheless, the ejection factor of 40 gives me concern. I'm kind of low, isn't it?
Yeah, what do you think about that, Scott? Is that a ejection? Tell us about ejection fraction. What is that, and is that low at 40%?
It's mildly low, and mildly low, let me explain. Ejection fraction, the main chamber of the heart is called the left ventricle. And when the heart pumps the blood with each cycle, it pumps out a certain amount of blood, not all the blood. And the normal ejection fraction is over 50%, 50 to 55. It's not 100. So your heart function is not 40% of normal. It's 80% of normal. However, like you said, you're functioning normally. You went 18 minutes on your stress test. Now, I have to defer, of course, to your cardiologist. This is, of course, a radio show. And I would also confer with Dr. Katz on how urgent the prostate is. Since they found the prostate, based on what you tell me, I would have that addressed first.
Oh, okay.
That's what I would do. But again, your cardiologist, I'm sure, has reviewed the test directly. If Dr. Katz tells me this prostate's going to be stable for a year or two, don't rush, and I'm not saying that's Dr. Katz's opinion, then I'd say, well, let's address the mitral valve and the atrial fibrillation. The other question is the severity of the leakage of that valve, and that is based on the echocardiogram. So with discussion...
They're rating it mild to severe, but moderate to severe, sorry.
Right, and you're a young man. I think that having the mitral valve taken care of will be important. Is it urgent? No. And I think this is where your urologist and cardiologist put their heads together, just like we're doing here in the studio. From my cardiology standpoint, if the urologist said, listen, this needs to be treated, I think with at a program where there's an anesthesiologist who is facile with cardiac issues, I think you should be more than fine to go through your surgery. Again, you have to clear that with your own physician.
Yeah. All right. Well, thanks for your phone call, Paul. And that was, so it does require a lot of coordinated care, things that we do at Winthrop, where we have the team of cardiologists and cardiothoracic surgeons. In fact, we have 4 chest surgeons at Winthrop, and we have probably about 40 cardiologists, don't we there, Scott? Yeah,
that's right.
Something like that. Now, he mentioned, we're going to get to a few more phone calls, but he mentioned that there may be a problem with his mitral valve, yet earlier in the show you were talking about your new procedure, the TAVR that you're doing at Winthrop to replace the aortic valve, which, by the way, for the aortic valve replacement, and you do it transcatheter is that without an incision?
It's a small incision. There's 2 approaches, either through the artery in the groin, and there's an incision that could be as small as a half an inch.
But you don't have to have your chest cracked open.
That is correct.
Wow. But can you do that and you have to stay overnight for that, by the way?
You're actually in the hospital approximately 4 or 5 days.
Okay. But you're not are you in the ICU?
Just overnight.
I see. But it's not as major as the open heart surgery. In terms of your hospital stay. That
is correct. The procedure, though, is geared to more elderly, rather debilitated patients. Mm-hmm. It is still not approved if a 50-year-old person comes in for aortic stenosis and needs treatment. They would not be a candidate for this new procedure, as the FDA is still investigating the longevity of the new valve.
I see.
So these people, even though it is less invasive, they have other illnesses that may keep them in the hospital a little bit longer. But going back a year or 2 ago, we had nothing to offer these people.
But what if a 50-year-old guy needs this procedure and he says, you know what, I don't want to have my chest open. I'd like to have this TAVR procedure. Would you do it, or can you do it?
No, we can't do it.
Okay.
And physically we could do it, but it's not approved. But also I would say to the 50-year-old person that the longevity of the new valve, we've only been doing this now for a few years. It's been studied for 10 years. And then I would also argue with the 50-year-old that our standard technique doesn't mean poor technique. The results is a greater than 95% chance of coming through this procedure without any problems. And like I said, with the new technique, you're in the hospital 4 or 5 days. You're in the same amount of time with the standard technique. So this is not someone who should say, oh my God, I have no options. The standard option is excellent. We treat hundreds of people every year with aortic stenosis using a very well-tested technique with an over 95% success rate, and these people get back to full activity, whether it's, again, running half marathons, going back to work, and the valves have a longevity of well over 10 to 20 years, depending on the type of valve that we use.
Sure. And do you do robotic surgery for any of these procedures? Have you started doing that? I mean, I know that robotics and prostate is caught on quite a bit.
Well,
is it the same with the heart?
Well,
surgery,
as you know, that Winthrop is also a leader in robotic surgery with gynecology, with urology. We have not used it for cardiac procedures. It is being studied throughout the nation. There are some limitations with that. Where we have used robotic surgery is actually with lung surgery, and that has really helped us quite a bit in that there's a limited access with getting through the rib cage. And with the robotic surgery, same with the urologic surgery, it allows smaller incisions, access to the structures that we have difficulty getting access to. With the heart, it is available. We have not done it at Winthrop, and there's very few institutions trying it, which that statement really says that it has not been perfected yet.
Right. And I know that you're also doing a lot of lung surgery there at Winthrop, and you're running a lung cancer screening program, a very active program at Winthrop. Tell us about that.
Right. We've embarked on a new screening program. We've known for years that trying to detect cancer early is better. I mean, everybody knows about mammograms with colonoscopies, PSAs.
Yeah, controversial though, with PSA,
right.
Because with PSA, although we can detect more, we're not so sure. We're probably over-treating. The same thing with the lung screening. Do you see that?
Well, for years people would get chest X-rays, and we've known that with a standard chest X-ray, which is an excellent diagnostic tool, there's a limit to how small the spots that they can see. And we know CAT scan, which is a non-invasive procedure, we can see much smaller lesions or spots. But no one ever knew, well, so we see them smaller. Are we really helping people?
Right.
The same controversy.
Yeah, same thing with PSA. We're
right.
seeing these really small cancers with the prostate. Are we really helping people?
But there has been studies now showing, and the studies have been done actually here in Manhattan, and studying people with risk factors. This is not everybody walking into your office, but if you're over 50 years old and you have a smoking history, that's key because that increases your risk. The data has just come out that if you do get this screening CAT scan and we find your lesion early, we do help people. So that controversy existed for years, and we've now started this program based on the data that has resolved that controversy.
Now, that screening CAT scan, is that paid by insurance?
That depends on your insurance company.
Uh-huh.
When we started on the program, we assumed that it was not, and we are finding now many insurance companies are paying for it.
Okay, so you get that. So you have a history of smoking in the past. Maybe you quit. No, you still need it. Let's say you smoked for 10 years and then you quit. Do you still need the screening CAT scan? Are you at risk of cancer even though you stopped smoking?
Your risk goes down with time.
Okay.
If you smoked for 10 years, but it's less than 10 years since you quit, yes, and you're over 50 years old. That's
okay.
Also, yes, you should get the screening CAT scan.
Once a year, the screening CAT scan, or how often do you do that?
It begins at once a year.
Yeah.
If there are findings of concern, we may say 3 months, but usually once a year. Yes.
Okay. All right. And we're doing that at Winthrop. We're running that.
Yes, we are.
Oh,
yes,
excellent. Okay. And I guess you have people to help. Well, if you're interested, that would be winthrop.org, and you have people that would coordinate that CAT scan and work with the insurance company, because people are always concerned, is the insurance carrier going to pay for that, and so maybe once a year you get a screening CAT scan.
Right. We have a full-time coordinator, and that is her job to help patients get through this.
Terrific. Yeah, and those CAT scans can pick up, I guess, much better than the old chest X-rays.
Much better.
Wow.
Much better.
Yeah. And what about the dose of radiation? Is that a concern over time? Because you're getting it once a year. People always, it's a lot of radiation there.
It is.
And that also can raise the risk of cancer, right?
Absolutely. But the studies that were done that alleviated this controversy have done what we call low-dose CAT scanning. And it's a very rapid test, and the amount of radiation is significantly reduced because in the beginning when doing this, that was one of the concerns.
Fantastic. At Scott Schuback, he was a wonderful guest this morning on Katz's Corner, and he's the chairman of thoracic and cardiovascular surgery at Winthrop. That's winthrop.org if you want more information. I think, what you're doing, Scott, with these transcatheter aortic valve replacements is really phenomenal. I mean, you can, especially you said, well, right now it's approved, I guess, for the elderly patient, but these are the guys that need it because for patients that, that are older, maybe a little sicker, it's going to be much more difficult for them to go through the standard, type of a procedure. So you'll be able to get them out of the hospital and for 4 days, and you have a new aortic valve, and you probably feel a lot better when you get that valve done, huh?
Well,
do you feel symptomatically that shortness of breath? Does that go away right away?
Well, the most gratifying part of this whole program, pushing all the science aside and what's happened, we have these people who say, I can't breathe. I can't play with my grandchildren. I can't do what I want to do. I used to go to the store. And we do this valve. They recover. They come back, and we have to do follow-up, and we want to do follow-up. And they come back, and they not run, but they essentially run into the office and say, thank you so much.
That's got to be gratifying.
That is one of the best things, and that's why we're here, and that's why this technology is developed.
Beautiful.
It really, we're helping the person.
Yeah, that's great. I mean, you helped them breathe, I helped them pee. And people say, why'd you go into urology? I say, well, if you have a guy that can't pee, and all of a sudden you do a procedure, whether it be a laser or plasma, but you really can change the quality of their life. And that's what you've done, and I want to congratulate you for running that program. That was Scott Schuback, again, the chairman of thoracic and cardiovascular surgery at Winthrop. That's winthrop.org. Scott, thanks so much for coming in this morning.
Thank you very much.
I really appreciate it. You were a terrific guest, very informative. We'll have you back on. Next week, Philippa will be back in the studio. We'll have another guest, and we'll bring more information to your health under the belt. Tune in every Sunday. This is Dr. Aaron Katz.